Okay, so this is Chapter 7, Masking and Audiogram Interpretation. We've talked a little bit about masking, and masking essentially involves the presentation of a sound to the non-test ear. And we want we do this so that we can ensure that sound from one ear is not reaching the other ear. So that will eliminate any contribution of the non-test ear to the test results, and you're going to see how that applies. So why do we use it? Why do we need it? It's used for the accurate assessment of hearing, depending on verifying the test results that they only reflect the information presented to the test ear, because we're looking for ear-specific information. When we conduct bone conduction testing, it's important that we use masking a lot to ensure that we're getting results from the test ear. Here are some concepts that we're going to talk about. Intraoral attenuation, minimum versus maximum masking, effective masking, overmasking, so there's cases where you can put too much noise into the non-test ear and it affects the test ear. The earbone gap, which we've talked about, and the occlusion effect. So we're essentially, anytime there's a possibility for what we call cross-hearing, we need to use masking noise. There's a concept called intraoral attenuation, and essentially it is a concept related to how much natural attenuation your head and skull provides from one ear to the next. Okay, and it depends on the different types of transducers we're using and so forth. So, but technically, it's a phrase used to describe the reduction of sound as it crosses the head from one ear to the other. That's intraoral attenuation, and we'll talk more about that. So some general rules for masking. We're trying to get ear-specific test results. Obviously, that's an important thing. Air conduction sounds presented at a very high intensity to one ear may cross over to the non-test ear, and it can do so via bone conduction. Okay, so we'll see some visuals for that in the future. Cross-hearing from the test ear to the non-test ear occurs when the stimulus intensity exceeds the intraoral attenuation. So when we use specific types of transducers, and in this example there's the supraoral headphones versus the insert earphones, we can expect that the head will reduce the amount of sound by 40 dB from one side to the other for supraoral inserts, and then about 60 dB for insert earphones. So a lot of people use insert earphones because they provide more intraoral attenuation, or intraoral attenuation is greater for insert earphones, and so it reduces the amount of masking you have to do. For air conduction testing, cross-hearing is possible whenever the level in the test ear minus intraoral attenuation is greater than bone conduction in the non-test ear. Now, for bone conduction, the intraoral attenuation theoretically is 0, meaning that if you were to play, let's say somebody had a completely dead right ear, and you were to play a bone conduction sound on the right ear, which is dead, so there's no usable hearing on the right side. If the left side is still functioning normal, they would hear that sound on the left side, even though it's being presented to the right side. And you'll see some examples of that. So, intraoral attenuation is always 0. We assume it to be 0 for bone conducted sound. Again, here's some of the principles. Intraoral attenuation. Acoustic crossover of sound from the test ear to the non-test ear occurs when the intensity level of the sound exceeds intraoral attenuation. Sometimes it's called cross-hearing or transcranial hearing. Now, masking is really complex, but I'm just going to give you kind of the surface level information, kind of general principles. Now, theoretically, here's the range for supraoral headphones, like your that we're about to see, and then there's the range of intraoral attenuation for inserts. So we use about 40 and 60 as kind of conservative measure. Again, intraoral attenuation for bone conduction is 0. That's what we use. We assume there is no intraoral attenuation because you can even put the bone conduction oscillator on the forehead, and it will be stimulating the better ear. So you can have a dead ear, a normal hearing ear, and if you put the bone conduction oscillator on the forehead, well then you'll get a response at a low level because of the normal hearing ear. All right, so here's a visual from the text that shows an intraoral attenuation of 40, 70, and then bone conduction. So this would be like through supraoral insert. It says 70. Some people use 60. There's no definitive amount. I usually use 60 to be a little more conservative to make sure we don't that we have effective masking. So essentially, it shows that a sound that's loud enough on the right ear can stimulate, if it's over 40 dB, that the intraoral attenuation value, it can stimulate the other cochlea. Same here. But with bone conduction, sound could come, when we're testing bone conduction, sound could be placed in the right ear and the left ear will respond. Okay. And then the masking dilemma. I don't really care that you know a lot about the masking dilemma, other than it occurs whenever the amount of masking that you're going to put in a non-test ear is essentially too much, and then it will mask the test ear. Okay, and there are certain cases where that occurs. So you can have undermasking where the masking noise is too low and the non-test ear may still contribute to the patient's. Minimum masking level is the lowest level of noise that just masks a pure tone or speech signal. Your initial masking level, it's the minimum level of masking noise necessary to produce a 5 dB shift or increase in air conduction thresholds in the non-test ear. Maximum masking, obviously the highest level you can use, and then overmasking, which is essentially when you have the masking dilemma and your your amount of masking is actually affecting the test ear. It doesn't happen too often, but it can. So we use a plateau method for effective masking, and at the plateau, further increases in masking levels do not produce a change in hearing thresholds for the test ear. The occlusion effect, and I'll show you a visual of that in a little bit. The occlusion effect is an enhancement or improvement in bone conduction scores for lower frequency sounds. It essentially happens when you occlude the test ear, so we don't ever occlude the test ear, and you'll see an example of that, because when you do that, you get this artificial enhancement or better hearing in the 250 and 500 hertz low frequency range. So again, we talked about intraoral attenuation as a really important component. The level of the bone conduction hearing result in the non-test ear is what we take into account, because remember, they're hearing from the test ear to across the skull to the bone conduction level in the non-test ear. Okay. Now, I'm not going to have you really calculate the need for masking, but essentially when masking of the non-test ear is necessary when the level of sound reaching the non-test ear via cross-hearing exceeds the bone conduction hearing thresholds in the non-test ear. So here's an example. So let's take a look here. So we're going to assume a level of cross-skull or interoral attenuation of 40 dB. Okay. So if the threshold in this ear, the test ear, is 80, okay, and we present the tone at 70, okay, 30 dB can get to the non-test ear. Now, if their threshold in this non-test ear at that frequency is like 10 or 15 dB, guess what? They're going to hear it, and you're going to think that they heard the sound in the test ear at 70 when indeed their thresholds are actually 80 dB. But because they hear it on the non-test side, you put a false result down. So hopefully that helps you understand that. So again, let's go over it. You present the sound at 70 dB on the test ear, okay? And their threshold is actually 80, so it should be inaudible. That's what should happen. It should be inaudible. But you present it at 70, 30 dB crosses over because of 40 dB intraoral attenuation. If their bone conduction threshold is better than 30 dB, let's say 10 dB, they're going to respond as if they heard it in the test ear. Hopefully that was helpful. So again, as a general rule, the test ear is not covered because of occlusion effects for bone conduction testing. And there's a visual where you'll see that. And again, we calibrate to certain reference levels, and it's all based on the idea that the ear is uncovered. So here is, here's the setup. Okay, so this is the right ear, and you have the bone conduction oscillator behind the right ear. Notice that we're not masking the right ear because we're testing the right ear. All right. And then on this side, if you flip it over, we're putting masking noise in the left ear. Okay, so in this case, we are testing a right masked bone conduction. And if you remember, the right masked bone conduction, trying to write on the screen, but I don't see there we go. The right masked bone conduction score looks like that, right? So that's the because it's facing the right side, so that's the right mask bone. If we flipped it and then we put the bone conduction oscillator on the left ear and put this on the right ear, then we would have a left masked bone score. Okay, so remember, right unmasked is here, left unmasked is here. That just shows where the oscillator's at in location. If there's no masking. If there is masking in the opposite ear, then you can say for sure that that bone conduction score is coming from either the right or left ear. So without masking, this is an important point, without masking in bone conduction testing, you cannot be sure exactly which ear the response is coming from because intraoral attenuation is 0. All right, different types of masking noises that we use. We can use a white noise or a broadband noise, which we talked about. It's really not too effective for pure, tonal sounds because there's all this extra noise in it. But for pure tones, we use narrowband noise. And I'll show you a visual of the spectrum. Speech noise is used when we do speech audiometry. So when we need a broad spectrum sound to mask speech, but not something with as equal intensity across the spectrum like white noise, we use what's called a speech shaped noise or a speech noise. And we'll show you that. So here's a visual of speech noise, okay, and you can see that here's actual speech, the dark line. Here's the masker, and it's pretty matched to the speech signal. So when we use speech noise, this is what the spectrum looked like. When we're doing, I think I created this. This has a center frequency of, I think, like 3,000 hertz or something like that. But this, now, they're usually much more condensed than this. This is a broader narrowband noise, but it shows you all of the energy. All of the energy is within this frequency band. Okay, and I just made that myself to show you what the spectrum of a narrowband looks like. All right, well, we're going to stop here, and I'm going to come back and do the rest with the interpretation.